So what we're going to do is we're going to look at the tongue, and we're going to use several models to kind of look at the tongue. So we actually have a model of the tongue. We actually have a real preserved tongue. And then the other model we're going to use is this model where the tongue has been cut. Okay. So the tongue itself is a muscular mass. And so the tongue is made up of muscles internally. Those muscles allow us to change the shape of our tongue. So interestingly, there's a gene mutation that humans have where some people cannot roll their tongue, other people can roll their tongue. And that is using the muscles within the tongue that we call intrinsic muscles. The muscles we learned in 241 that move the tongue, and we can see the genioglossus here as one of the examples, were extrinsic muscles. So when we're looking at extrinsic muscles, we have the genioglossus we can see here. Unfortunately, the hyoglossus is just lateral to that. And then over here in the neck, toward the back here, we can actually see the styloglossus muscle sitting right in there. Those were extrinsic muscles that are on the outside of the tongue. So when we're looking at our tongue, we can divide the tongue into the body of the tongue, which is this portion of the tongue. And then this portion of the tongue that we typically don't see that anchors the tongue to this bone, which is the hyoid bone right here, which is the root of our tongue. So when we're looking at the upper surface of the body of our tongue, which is what we can see in this model here, and we can see in this here, then the upper surface of the tongue is called the dorsum of the tongue, and that's a carryover from the fact that anatomy was done on four-legged animals. When you're on all fours, the top of the tongue is in line with your back, and therefore it's a dorsal surface. So this is called the dorsum of the tongue. And then the tip of the tongue is called the apex of the tongue, and the sides of the tongue are called the margin of the tongue. So we have margins, dorsum, apex, and this whole area is the body of the tongue. So just as a quick review, when we talked about these in the nervous system, most of the tongue is covered by real fine upward projections that give this tongue a real rough surface. Those are filiform papillae, and they contain touch reception, temperature reception. And then we have some rounded ones over the dorsum of the tongue that are small, that if we cut them on their side, they look like little toadstools. So these are called fungiform papillae, and they contain taste buds. The margin of the tongue has repeated folds on it, so these are called the folate papillae, and they contain taste buds. And then we have a big, large circular mass that forms a V toward the root of the tongue, and those are called circumvallate papillae. So you can see those on the real tongue here, and you can see this on this model tongue. Now, if we orient the model tongue like this so that we're kind of looking at the same image, then you'll begin to understand what we're actually looking at here. So this is the epiglottis, and that's the same thing you'd be seeing here is the epiglottis. And this is designed to close off this airway. Now the back of this has been cut off here, so we can actually see the vocal folds in the larynx in this model right here. So you can see the true vocal folds and the false vocal folds, the two folds that we're seeing right in there. And we'll talk about those when we do the respiratory system and talk about that whole structure that we're seeing in there. So that kind of concludes our anatomy of the tongue. So when we look at our teeth are in sockets within our jaw. So as you'll recall, our teeth fit down in sockets in the mandible or up into the maxilla. So when we pull this apart, we can actually see that each tooth has its own process, which is called a alveolar process, that it fits down in the mandible or the maxilla. And those create ridges that we can actually feel on ourselves. So when we put the jaw back together here, what we'll be able to see is that the thickened area of the lining near the tooth is called the gingiva, or your gum. And one of the things that happens with age is the gingiva decreases in height. And when you go to the dentist, they always take a little probe and call out numbers, 1, 2, 3, and you don't want those 4s or 5s. And that's showing you that the gingiva is actually decreasing and in height and dropping down the tooth. And I'll show you the problem with that as we go along. So if we actually look at a tooth, and the part of the tooth that extends above the gingiva here is called the crown of the tooth. The part of the tooth where the gingiva starts and drops into the alveolar space we looked at is called the neck. So if we're looking at this tooth, then this is a crown. So what we were just doing is we were looking at the crown of the tooth as it was setting in the jaw. And then this white area here where the enamel greatly tapers is called the neck of the tooth. And then where the white stops here going down is the root of the tooth. And so we were just talking about how the gingiva recedes along a tooth. Well, the problem is it recedes down the neck. And because there's not a lot of enamel covering the neck, it allows for easy cavities, which then creates problems with the teeth. So when we look at a tooth internally, so the crown of the tooth is largely made up of a very hard substance, one of the hardest substances in the body called the enamel. Most of the inside of the tooth is made up of a calcified matrix similar to bone that we call dentin. And then the surface of the root of the tooth is covered by a less hard material that helps adhere the root of the tooth into the socket, which is called cementum. And then what would attach to the cementum would be little ligaments we call periodontal ligaments. And the periodontal ligaments would then cross and attach to the periosteum of the bone so that it would keep the tooth in place. If you've ever had a tooth pulled, you can actually feel those little periodontal ligaments popping and breaking as they pull the tooth out. So the inside of a tooth is hollow, and we have to have a way in which we get a blood supply, a vascular supply, and a nerve supply into the tooth. So at the end of each root, we have an apical foramen, and then the canal that goes through the root is called a root canal, and then the main portion of the tooth up here is called the pulp cavity. And what we would have in that is a gelatinous mass that they've tried to depict with this stuff that would help organize the vascular supply and the nerve supply. So when you get cavities, you get an erosion of the enamel. Once it gets through the enamel, it erodes the dentin quickly, and it gets down into the pulp cavity where the nerve is. So the first thing you would notice is your tooth becomes very sensitive to hot or cold. And because we have now less layering between this and the actual nerves of the teeth. So when they fill a cavity, they drill all of this decomposing stuff out, and then they fill it with a material that prevents that from happening. Now sometimes if it goes clear into the pulp cavity, you get an infection in here. You can also actually get it in other ways. And then your tooth becomes really infected, inflamed, your jaw swells, hurts. So then what they'll do is drill a hole down into this pulp cavity. They will lose little wire-like things and destroy the nerves coming up through the roots of the tooth, and then they will put a material in that fills in this whole root area of the tooth, the root canal. So that's called a root canal when the dentist does that.